I would like to introduce and turn it over to Dr. Judd Mao, who's at the Duke Cancer Institute. Dr. Mao and I have actually worked together on various prostate cancer projects in the past and have known each other for a long time. And with that, I will turn it over to my esteemed colleague, Dr. Mao.
Jason, thank you very much. It's a pleasure and honor to be here, be with you today, and also thank Carla for setting this up and the team at ExoDx. I was really excited to hear the data that Jason presented, and I'll try to put a little bit of that into my comments. So I do bring greetings from the Duke Cancer Institute and the Duke Prostate Center in beautiful Durham, North Carolina. Next slide, please. And I think from a clinical standpoint, every clinician certainly listening in today on this program is aware about that we all love PSA, but PSA has its challenges. Its PSA screening has been widely used now for 30 years. It does have relatively poor specificity. PSA is not prostate cancer specific. As we all know, it can be elevated in men with BPH or prostatitis. And in the 30 years of use of PSA, it's had some up times and some down times. The down times occurred in 2012 when the U.S. Preventative Services Task Force gave the PSA test a D rating, basically saying that there was more harm than good. And that's been a controversial rating from ever since it was announced in 2012. Then in 2018, they improved the benefit of PSA to a C grade, basically saying that there was evidence supporting PSA testing, particularly between men between 55 and 69 years of age, but obviously very controversial. Next. And a challenge again over the last 30 years is what constitutes an abnormal PSA level? What's the proper cut point to call for a biopsy or a normal versus abnormal? And you see listed on this slide anywhere from 1.5 all the way up to 10. And in fact, there's just a recent editorial that came out in the New England Journal of Medicine just in the last couple of days calling for potentially using a cut point all the way up at 10, which is I'm sure that editorial or that commentary in the New England Journal of Medicine is going to generate a lot of controversy and further letters to the editor. But anyway, the gray zone, the classic gray zone, has generally been with a PSA between 2 and 10. And there are quite a few papers, particularly in young men, where they have termed a danger zone of 1.5 to 4, where perhaps in younger men we should use a lower cut point. But the key teaching point, PSA has value, but it's not perfect. Next slide. And there have been many tools to increase PSA specificity, age-specific PSA, race and ethnicity adjusted PSA, PSA velocity and density, percent-free PSA, biomarkers, risk calculators, and Jason refers to some of these risk calculators, and then MRI imaging. So there's a lot of things out there trying to improve on the utility of prostate cancer screening. Next slide. And this slide just lists some of the possibilities: blood tests, urine tests, blood and urine tests, tissue tests, radiomics, including various ways to look at multiparametric MRI. As far as urine tests, the ExoDx Prostate Test, which Jason talked about earlier, is in the category of a urine test used to improve on basic PSA. Next slide. And it's been termed a Wild West between tissue, blood, urine, multiparametric MRI, biochemical, genomic, epigenetic, and radiomic. So it's a lot of controversy, a lot of literature. Things are certainly becoming clear on the value, and you heard the beautiful presentation of Jason and this first randomized controlled trial that was conducted, which really helps, I think, helps to clarify the situation. Next slide. The challenges is what we really need in the clinics and what is a follow-on test after PSA to stratify the risk of clinically significant prostate cancer. In other words, The basic PSA test is not going away. No one is proposing that we get rid of PSA, but certainly PSA is going to be your basic test that's going to be done in primary care. And after that test is done, then we're looking at ways that we can improve on who gets a biopsy. And the urine test, the ExoDx, is really where we're positioning this. Where I position in clinic is I put it's between the PSA that the primary care physician does, or as I do as a urologist, and the biopsy. Putting something in many cases in between, particularly in those gray zone PSA numbers, to help improve clinical care. Next slide. So shared decision making, how do we use this molecular urine test to make better decisions with our patients in the clinic on a day-to-day basis with regard to prostate cancer and biopsy? Next slide. And when we were preparing this, obviously COVID is in everyone's mind, and the EPI test has been particularly useful over the last 6 or 8 weeks during the COVID pandemic to help fine-tune our decisions. And as Jason eloquently talked about, the EPI validated cut point is 15.6. That's what's in the package. That's what's the classic cut point below which there's a low risk of high-grade prostate cancer. However, we've been using a little bit modified version of that to keep it simple during the COVID epidemic. In general, the EPI scores below 20 are generally watched and wait, follow up in 6 to 24 months. The intermediate risk EPI scores of 20 to 40 are where it depends. It's acceptable for short-term postponement during the EPI or during the COVID pandemic. And then certainly for patients who have a very high EPI score greater than 40, we're trying to figure out to generally get those patients in for a biopsy right away. And even over the last 6 weeks at Duke, and it just is local depending on your conditions related to COVID, but we've been continuing to be able to do prostate biopsies selectively based on high risk. And we'll talk about that in a minute. Next slide. So we saw this slide before. This is the ExoDx Prostate Test. You heard about the sensitivity of 92% and the negative predictive value of 91.3 using that cut point of 15.6. And so what I want to do next is just illustrate with a couple of cases. Next slide. And we're going to look at a couple of cases who had the EPI score below 15.6 and a couple of cases that were higher. But in those patients who have the favorable EPI score, the monitoring options that we've been employing are refer back to primary care. They may be managed with the urologist and continuing to see the urologist, and also you can reassure these patients and ease of anxiety. And that's important all the time, but I can tell you that's even more important now during the era of COVID, because if you get a reassuring score, it's certainly very good that you can tell that patient, hey, you're fine. We don't have to see you back until we have a vaccine available for COVID, and then hopefully things will be better back to normal. The other thing is, Jason made the point that the EPI score, the test that you send off, you do not supply any clinical information with that. The test stands on its own, meaning that molecular score, that this test is based on molecular analysis of these exosomes. Nevertheless, in clinical practice, I mean, sure, we're using clinical factors. So I have the EPI score, but I'm taking into account the patient's age, family history, prostate size, whether the patient has an enlarged prostate, history of a prior negative biopsy, the patient concerns, prior PSA history, and even other markers. So we're not, even though it's wonderful to have this score independent of clinical information, when I'm in clinic, I'm certainly taking advantage of the information I have at hand. Next slide. So here's case study number one. This is a 54-year-old gentleman who presented in April of 2019. His EPI score was 3.2, very low. PSA was 3.15, and you might ask, well, why was he being sent to the urologist? Well, his baseline PSA was 1.8, and he had had testing since 2015. And when his PSA went to 3.15, he was referred by primary care to Duke Urology. He had no family history of prostate cancer, no prior biopsy history, but he did have a history of lower urinary tract symptoms, or LUTS, and had been previously actually on finasteride. Next click. So on physical exam, he had a 40-gram or 40 cc prostate, which was felt to be benign and felt to be consistent with benign prostatic hyperplasia. The plan was for reassurance to refer the patient back to the primary care physician and follow up with urology as needed. In preparation for this presentation, I recently looked at this case again, and he has been followed by his primary care physician in January of 2020, and he was initiated on tamsulosin for BPH. He did not have a PSA at that time, again, following some of the other guidelines. Since he had a very reassuring EPI score, the plan by the primary care physician will be to repeat the PSA in 2021. Next slide. So case two is a 64-year-old man also presenting in April of 2019. His EPI score was a little bit higher at 8.95, but still well below the cut point of 15.6. And he was referred to urology by primary care for a PSA of 8.02. He had no family history, no prior, he did have a prior negative biopsy sometime in the past before he entered the Duke healthcare system, and currently he has mild lower urinary tract symptoms. Again, on physical exam, he had a 40-gram or 40 cc prostate, consistent with BPH. Again, the plan was reassurance, initiate medical treatment for BPH, or in this case, he was also recommended to start tamsulosin, and his follow-up in urology now in February of 2020, fairly recently, just slightly shy of a year since he had his initial EPI score. His PSA was 6.59. Let's go to the next slide, and you can see the graphic on PSA, and you can see that this gentleman in follow-up, his PSA actually went down to some degree in follow-up. And so reassurance seemed to be the right decision for this patient. Again, low risk for prostate cancer, the right treatment for the right patient, which was reassurance and routine follow-up. Next slide. Now, management above the cut point. Next slide. Again, above the cut point of 15.6, there's a higher risk of high-grade prostate cancer, a higher risk of Gleason 7 or greater. And again, I put the bullet points in here at the top of during the COVID epidemic, we're using thematically the level of the EPI score, although we're not sticking exactly to the cut point of 15.6. And we're also considering clinical factors. Next slide. And we put this in at the last minute. This is our actual taken from our Duke protocol. We're having a every Friday pre-op conference during COVID to discuss surgical cases, and we also have stratifications in here for biopsy. So high-risk patients, and that would potentially be a high-risk patient who had an EPI score greater than 40, would move directly to biopsy. Intermediate risk patients would be an EPI score between 20 and 40, and low risk men would be less than 20. Next slide. And you can see on the next slide that the priority 3, which again are going to be the high risk patients, we're doing those biopsies now. The mid group, the priority 2, we're delaying those 6 to 12 weeks, and the priority 1 are delayed 3 to 6 months. Now, again, this is our personal triage plan during COVID, and this is related to the virus statistics at our hospital, and this is adjusted, and this may be variable depending on the area of the United States or globally where you're practicing. But this, I wanted to put this in for timeliness, showing how we're using this in real time to help make the right decisions for the right patients at the right time. Next slide. So case 3, this gentleman had an EPI score of 21.39, above the cut point of 15.6. This was from October of 2019. His baseline PSA was about 2.5, and he had been undergoing screening since 2015. And when his PSA jumped to 4.71, his Duke primary care physician referred him to Duke Urology. He also had a prostate health index test that was obtained that was 79.8, which is also high risk, and his maternal grandfather died of prostate cancer. So all the factors, EPI score, prostate health index, and his family history pointed to a higher risk of prostate cancer. Trust biopsy October 14th, 2019 showed high-grade prostate cancer in 12 of 12 cores. CAT scan and bone scan were negative. He elected to start androgen deprivation therapy and intensity modulated radiation therapy December 3rd. Now, I might add that these 4 cases, and I'm going to show you one more, were randomly selected and given to me before this presentation. And in fact, when I got these cases with the EPI scores, that's only then did I go and look at the clinical information. So these cases were not selected based on the final output. They were solely selected based on the EPI score, and then we made the slides from there. So I just point this out because I was actually kind of surprised when I looked at this EPI score and saw this situation, but this is a real case and shows that above that cut point, along with these other factors, this guy had the real deal. I mean, this was real, important, clinically significant prostate cancer. And what's really interesting about this case is that I'll bet you, he could have easily been blown off. I mean, his PSA was only a couple points above the baseline, and I could see many scenarios where a patient like this might have just blown off a PSA that went from 2.5 up to 4.71 and could have had a significant delay or even refusal of a biopsy. So again, right treatment, right patient, right decision, right treatment. This patient appropriately was diagnosed with high-grade prostate cancer and is undergoing treatment as we just recently. Next slide. Case 4, again, is really interesting, as again, when I got this information on case 4, all I knew was that this was a patient who had an EPI score of 89.3, and so his EPI score was 89.3, PSA was 4.43, baseline was 2.5. So he had been screening since 2014. So his total PSA really did not jump that much. It was really the EPI score that was a tip-off. He did undergo an MRI and had a solitary PIRADS 5 lesion, and the prostate volume was 50 cc's. Next, click it again. So he underwent an MRI plus a 12-core biopsy October 1st, 2019. Interestingly, he was only found to have Gleason 3 plus 3 equals 6, which is low-grade prostate cancer in the fusion cores, but his 12 systematic cores were negative. So he elected initial active surveillance. And in preparation for this presentation, I found this information fascinating because His most recent PSA was 7.01. Next slide. And there you can see the PSA going up. So and if you can go back to the previous slide for just a second. So based on preparation for this meeting, I've contacted this patient for a repeat MRI and a repeat biopsy. He was not originally, he was one of my partner's cases, but in this case, I really think the EPI score has done better so far than anything, because that's a really high EPI score. And I think we just missed a high-grade cancer on the previous biopsy. And this guy, because his PSAs now continued to rise, he had that EPI score. I'm worried he needs another biopsy. So we'd like to report back to later to let you know what the repeat MRI and repeat biopsy are going to show, because I do think this gentleman probably has more important cancer than we found so far. Next slide. Next slide. So how are we using this also further during the COVID pandemic? Well, telehealth in all of our practices has increased dramatically, and we are now also able to use EPI score or EPI, where patients can sometimes come in as a nurse-only visit at times when the clinic is very quiet, to adhere to extreme social distancing. And there's now available a collection kit that patients can do at home, which we've just started to use at Duke in the last couple of weeks, and perfect timing with the COVID epidemic to try to again improve on social distancing and ways to do these things without having patients to come into the hospital or the clinic. Next slide. And so as Jason showed the snapshot of the data on our first 125 patients, we now have data on over 250 patients that we're currently analyzing, helping us for pre-biopsy risk stratification. The urine collection is easy in clinic. There's no clinical information needed on the requisition form. Results are available in less than 1 week, and they go into our the Duke Epic and can be sent out to patients in MyChart with standardized education. We have independent data point for risk of high-grade cancer, the 15.6, and we're also done the simple modification during the COVID epidemic. We're currently planning a collaboration with the Duke Cancer Institute urologists and our primary care network on a randomized trial to incorporate EPI into our primary care to make our interaction with urologists more efficient. And now with a direct-to-patient home testing trial, this is, I think, certainly exciting times. Next slide. Again, the future plans is looking at the continuing experience and our planned collaboration between Duke Cancer Institute and the Duke Primary Care Network with a randomized trial under development. I do want to just mention before I close, why is this so important, especially with regard to primary care? Well, primary care now have been re-engaged in PSA. They're now being told by the U.S. Preventative Services Task Force that, hey, PSA may not be so bad, especially in the men between 55 and 69. And at Duke, we have even a more aggressive effort with primary care related to high-risk individuals and African-American individuals and men with a family history. But the primary care are not that comfortable using PSA. They do no longer perform digital rectal exams, so they're unable to assess the prostate size. And so deploying something like the ExoDx urine test after proper training may be able to improve the efficiency of our practice. And one of the most important things that Jason presented from this randomized trial with Blue Cross and Blue Shield of Maryland was the compliance. It's amazing how often patients just don't show up for a biopsy or refuse a biopsy. And so by having Exosome DX in the practice and by improving on the compliance is really can help our efficiency, especially as urology is a shortage specialty. We need to make the most of our providers. And so this is a test that we believe can really help in that in that initiative. Next slide. So again, I really thank you very much.